Well, thank you so much for coming. We're all very honored to be here as part of this conference. And when Lior invited me and I heard the title was Injury Analytics, the first thing I thought of was we really are woefully underrepresented in the area of analytics when it comes to sports medicine. And it's a conversation that I've had with several people over the years, because one of the things we're always trying to figure out is how can we better keep athletes on the field? How can we study injuries and use that information to help keep athletes on the field, whether it's professional athletes or youth athletes and everything in between? And one of the people who I think is really pioneering in that area is Stan Conti. And so it's a real pleasure to have him here, because he has been looking at this concept in baseball for a number of years. And Stan's with the Los Angeles Dodgers, and he's going to talk to us about risk management in professional baseball. So I'm going to pass it off to him first.
Good morning. It's good to get here at 9 o'clock in the morning after being in Boston all night. I think there's probably a high injury rate at the hotels. I'm going to talk about the importance of injuries, which seems somewhat commonplace, but amazingly in professional sports, it's sort of like the weather. Everybody talks about it, but nobody seems to do much about it. You try to predict it, but even that becomes difficult. My little trek started about 15 years ago in 1996 when I was with the San Francisco Giants. We had a new general manager, Brian Sabian. At that time, San Francisco, it was a nice media market, but a very small baseball market. So there wasn't a whole lot of money. And one evening he called me and said, in 1997, we can't afford any injuries. We can't get replacement people. We have to keep our 9 guys on the field. Can you develop a program to do that? And of course, I was young at the time and probably more stupid than I am now. And I said, sure, no problem. So we devised some programs that we thought would prevent injuries. But the first thing I said is, okay, if I put an injury prevention program in, how do I know it's working? So I asked a simple question. How many injuries did we have last year? It took me 2.5 years to find that answer. In 1996, the internet was very slow. Nobody looked at it. The disabled list was not published. It was a well-kept secret in Major League Baseball. It was in USA Today. Every Tuesday they would list the injuries, the people on the disabled list. So every Tuesday I'd write them down on a spreadsheet, which was archaic at the time. We couldn't find any of the answers to that. And that sort of started me on this whole trek that we really don't know how many injuries occur in professional baseball. And therefore, how do we know if anything's prevented? I'm going to show some slides here real quick to kind of demonstrate I think I'm going to show some slides.
Oh, no, you're on that.
Okay, so I'll sing and dance here for a second.
No, not that.
So yeah, she's seen that. One of the biggest problems is understanding that there is a problem. And for years and years, although it doesn't seem right, nobody seemed to know how many injuries and didn't know what to do about them. And every time I talked about this, people would say, well, it doesn't matter, you can't do anything about them anyway. With the San Francisco Giants, we were able to put some programs in that kept our disabled list down low. But with the advent of great physicians, great techniques, great surgical techniques, improved rehabilitation, unbelievable strength and conditioning programs, injury rates continue to go up. Now, there's a lot of people who don't believe they're going up. There's some that actually believe they're going down. So if I get my slides up, I'll be able to show you a graph that shows that. This is sort of like when you start doing the shadow things.
But I do think one thing that's interesting is when you go to medical conferences and people are talking about what Stan said, the techniques are better surgically, the rehab strategies are better, and we all feel like we've really made improvements. And when you get to the bottom line, and Stan and I talk about this throughout the baseball season, the DL days are not dropping. So how is it that we feel like we're doing a better job in terms of medical management?
One of the biggest problems is that until 2010, we really didn't have an injury database. The disabled list is not an injury database. It's a roster management tool. It's designed so that if a player is hurt, you can replace that player with a healthy player. That's what it's designed for. And so in regards to the data, it's not clean data. We have dirty data. And when you talk to all these people on the sabermetric side, no one questions if Joe Smith had 17 home runs last year. No one says, well, maybe he had 14, or maybe he had 22. We know it's 17. It's clean data. Injury data is dirty. We're not really sure what it is. We're sort of implied certain things. Some people are on the disabled list that maybe not supposed to be there. Other ones stay on longer for roster management techniques and strategies. So we don't really have that. So what we did initially is we started looking at the disabled list dating all the way back to 1989 to see something. And one, I wanted to report the data in the medical literature. There's only been 2 articles in all the medical literature that talks about injury rates in professional baseball, which is unbelievable. First one was in 2001 that we wrote, and we were just trying to just tell people how many guys were getting hurt and how many people were put on the disabled list. But what we found was a slope that was straight up, continuously increasing 4 to 5% per year, and that was to 1999. We thought, well, what is this about? And so we kept tracking it. And then something interesting happened. After 2002, injuries went down. There was a big trough. In my slide, you'll see a straight up to 2001, 2002, and then it troughs from 2003 to 2006. Now, when I'm doing this, I'm thinking, geez, Major League Baseball's got its stuff together here. We're changing this. In 2007, it's shot right up, and it's been up, and last year was a record year in disabled lists. Now, another guy wrote an article. I'm glad he did, so I can say this, and I don't have to say it myself. 2002 to 2007 was a unique time. Depending on who you believe and what you believe, that was the steroid era. And in 2006, Major League Baseball enacted a much tougher drug program, including the banning of amphetamines. Coincidence? I don't know. But it's interesting, it's shot right off there. And then, instead of being an anomalous year, it kind of peaked out, and last year, 29,000 days were lost to players.
It's a lot of dollars and cents.
$600 million last year alone, $2 billion in the last 4 years has been lost to player salaries who don't play because they're hurt, plus replacement costs at minimum salary. So it's really more than that. In addition, when you start looking at this stuff, Major League Baseball, with a bunch of us involved, have developed a new injury surveillance system that is more accurate, that shows the disabled list undervalues the numbers.
Hey, there you are.
Okay,
your time's up.
Yeah, that's right. You guys are going to see this. I did it, so you're going to have to see it. So, sorry. That's just saying that the DL is... Okay, here's that time period, and this is since 1998. So imagine that from 1989 all the way up, it still is going up. So it's a significant trend. These are the dollars. I mean, even in baseball, 600 million starts to add up a little bit to me. This is each and every year. One of the things is we've devised what's called a hit system in Major League Baseball that actually is going to be able to, not quite yet, but it's going to be able to really give us the idea of how many people are hurt. So I'm going to kind of skip some of this stuff. One of the things you're going to see in these next slides, I'll go very quickly because Stefania will shoot me if I don't, is that starting pitchers are at the high risk. They're typically the most paid too, other than first baseman. So now we got the most important, the highest paid, with the highest injury rate. The injury rate is 50%, okay? When I first did these numbers based on total rosters, I came up with 50%. I said, that it can't be true. That means that every other pitcher goes on the disabled list every year. That's a starting pitcher. Well, when you start looking at your rosters, that's about 2.5 starters. And unfortunately, that's really, really true. It's highly unlikely that in a team will have 3 starters that make 30 starts, mostly because of injuries. Some because they're not very good and they go back down to the minor leagues. But starting pitchers, and we broke it down to left-handed, right-handed starters. One of the things you see is that left-handed relievers don't have as high an injury rate as the other guys. Whether that's because of the specialists and the fact that they don't pitch a whole inning sometimes, Pedro Feliciano aside, they don't get hurt as much. So when I'm looking at these things, what my job is the general manager calls me and says, we're interested in Joe Smith. Give us the relative risk of what's going on. Well, that sounds okay, but it's really unbelievably difficult. One, because no studies have really been done. Now, there's been some very good studies in the cyber world, in Baseball Prospectus. Jeff Zimmerman has written some very, very good articles. Recently, Russell Carlton wrote a very good article last week that actually he kind of got it. And through all his statistical analysis, he said, well, there's a really good chance if you're on the DL last year, you're going to be on the DL this year. Well, that seems really intuitive, but for a long time we didn't know that. So what I end up doing is looking at different parameters, different variables, and these are just a list of some of the variables that we look at. Demographic-wise, let's see if I can go ahead. Age, position's huge in regards to this. First basemen don't get hurt as much as right-handed relievers.
Kick you, Stan.
Okay.
I said I'm going to move you along.
Yeah. All right. But anyway, these all in there, and the statistical challenge is really to figure out which ones represent 80% of the data. We know that 20% of the variables will give you 80% of the results. We just don't know which ones, and we're constantly going on that. And in baseball, we are seeing a lot, again, in the cyber world, is that we're looking at a lot of pitch FX data to see if we can see when an injury is coming and whether a guy is recovered. So,
Thank you. We're going to switch gears a little bit now. That's looking at some of the risk assessment in baseball and turn to the treatment side. And we're very lucky to have Dr. Peter Wehling here from Germany. Came all the way from Germany to talk about Regenikine, which he developed. And I'm going to just leave it there and allow him to explain it from here.
Thanks
Can you
a lot
pass this,
for
Stan?
inviting me.
Can you pass
Can you hear me? It's okay? Is it okay? Can you? I don't know if the sound is okay?
Okay.
Thanks for inviting me. Pleasure to be here on the stage here. And actually, I myself, I don't know if there are slides. Yeah, right. So actually, I'm an orthopedic surgeon and spine surgeon from started, and I saw some pitfalls in surgical procedures, so I got very interested into biological approaches, and it's very interesting what he told about the incidence of injuries in sports, and I think one big factor is age, and we were very thrilled and interested to create value for the sports people in a more advanced stage where they're older, because the incidence of injury is also a function of age, as you described. So we got very much interested how we can create value to the end of the career of the elite sports people. And just to mention also here, we also collaborate clinically with Dr. Schottenstein and Dr. Kaplan in New York, and with Dr. Renner in Santa Monica. And perhaps the next slide,
Oh, you have
please. Okay, I have to. So, the problem with treating sports people in special or in general with patients is that actually surgery is a very advanced tool, but you do not treat the underlying disease process. And drugs in general treat the whole body, but sports people have very focal syndromes. A knee problem or a hand problem. And the problem with the drugs, when you treat, they're all in the body, but they're not in the target area where you want to have them. And we also know that proteins have a very high therapeutic potentials. So the problem treating sports people is a targeting side effect issue. doping issues, and the chronicity of disease, actually. And I always have to look on the side here. The original basis for our work was that there is a mechanical component of injuries and cartilage destruction, a mechanical but also a strong biological component. And we know pretty well that there is a mediator that actually drives the destruction of cartilage. It's called interleukin-1. And there is a natural antagonist to it, the interleukin-1 receptor antagonist. And we have actually developed a technology where from your own immune cells you can deliver very high levels of the interleukin-1 receptor antagonist and other growth factors. And just to be clear, it's not PRP or stem cell or ACP, it's a complete different technology. I always have to push here. You know what you do, one feature of the procedure is that certain immune cells, when they get adherent to surfaces, they produce high level of these healing factors. And this is actually what we use. And you can see that you create from your own cells as proteins that actually promote repair and regeneration in a way that is naturally not so occurring. So we really can enhance this natural process into a much higher level. So what you do in principle is you take blood, you incubate the blood over a certain period of time, and then you have actually a serum available on stock, or you can use it for the course of the treatment. And just for you to let you know, the World Agency Against Doping has cleared that as non-doping, just to be clear about that. It's used clinically for osteoarthritis, cartilage injuries, lumbar spine problems, but also muscle regeneration and tendon. And we know actually that the serum attracts stem cells to the area, but it's not, you know, it attracts cells that promote the healing too. Approximately 280,000 injections were done in humans, but also in racehorses. 10,000 racehorses were treated. And racehorses are interesting because they don't have a placebo effect. When something works in racehorses, you can measure it very well, and because the horses don't know what they get, they're an interesting example, you know, how it works. So muscle regeneration, we know there's a strong promotion of it. Cartilage defects in different joints, ACL injuries, and also lumbar radiculopathy. Perhaps interesting, I didn't put a slide, but we found the genes to predict outcome in cartilage defects. I didn't do an extra slide with it, but we have a pretty clear understanding when a patient and a sports person is at risk, and we also can, depending on the genotype of the sports person, we can tailor the composition of proteins to get an optimum outcome. That's interesting. That's a new area that develops right now. And this is a little bit complicated slide, but it has to do with the treatment effect, treatment size. The goal in sports people is to have a high function, and a caliper from 0 to 0.2 is no effect, 0.2 to 0.4 is a weak effect, and from 0.6 on you have a strong clinical effect. And you can see when you look on the slides, you can see that the serum has a very strong effect of the function of the player. I think operation and arthroscopy have clearly their stand, but it depends on the single case what you treat. They can have good results when there's a mechanical problem, but when you have biological problems in the joint, that's very successful. And I can say it with Kobe Bryant because he made it public. He was one of the people who even thought to finish their career, and we did a treatment, and it had a strong effect, and we tailored the therapy, and so it doesn't work in every patient, but in average we see a good effect in 80% of the patient, and it's a very powerful tool to have some functional impairment for the people, what they're really looking for the last 2-3 years of their career. And I think there we can create some value. So
let me ask you, Dr. Vidling, because I think people might be wondering this. We've heard of some of these high-profile athletes you mentioned, Kobe Bryant, Alex Rodriguez, who have come to Germany to get the treatment. Why do they have to go to Germany? Is that not available in the United States?
no, it's also available in New York and Santa Monica, but you know, the high-profile people sometimes decide to go to the inventor. So actually 90% of the patients actually are treated on the sites in the US. But one good player treated in Germany brings 5 to 10 players to our collaborators.
So the treatment that athletes or anyone could receive in the United States is identical to what they could receive in Germany. There are no restrictions in the United States.
We know the
relative
clinical
to this
results and the composition, the biological composition is exactly the same.
All right. Thank you. We'll come back to pose some more questions about this in a moment, but I want to pass the baton over to John Brenkus. You probably all recognize him from Sports Science, which is an integral part of our coverage at ESPN. And he has brought a DVD clip that they made specifically related to concussions. And the two of us are going to talk a little bit about concussions because it's a topic that's hard to ignore in the sports world right now. It's been so high profile. So, John, maybe you can introduce the clip.
Yeah, we on Sports Science, you know, we've looked at all different kinds of injuries. You know, the reason that an injury happened. You know, what's the rehab involved with it? What's the frequency that it happens? And today, concussions is by far the biggest topic in the injury world. I think that what we should do is we should watch the clip because we've done so many studies and there's so many numbers that are just staggering. I think that we should watch the clip and then just have a brief discussion about what do we do about concussions and how should we actually view it.
Every year, over 100,000 concussions occur in all levels of football. And 60% of these are from head-to-head collisions. In an impact lasting just 15 milliseconds, a player's head, on average, experiences almost 100 Gs of force. And collisions on special teams can result in forces of up to 190 Gs. In the NFL, the average speed of a head-to-head impact, the velocity of both heads combined, is 20 miles per hour, with the struck player's head decelerating 14 miles per hour. According to studies done by Sports Science's chief medical advisor, Dr. Basil Aish, this 15 millisecond impact is equivalent to getting smashed in the head with a sledgehammer. In the last 10 years, the average number of days a concussed player is out has more than doubled, and even improved helmet technology is only able to reduce an 80 G impact to 40 Gs, still several times when an F-16 pilot experiences, and more than enough to cause a concussion or neck fracture. For Sports Science on ESPN, I'm John Brenkus.
So that's just a very, very brief clip on the different studies that we've done. The first thing everybody always asks me about, you know, what should we do about concussions, especially in the NFL? What's interesting to me is that there's so much focus on the NFL. People are so obsessed with, well, what do you do about concussions in football? And I always like to turn that question and say, but I don't know why we're focused. If we're really, truly serious about the impact of a concussion, I don't know why we're obsessed with football. I'm like, look at hockey, look at the X Games, look at boxing, pick all the sports. The idea of that, the concussion is a very serious injury. It is, but I think that we're almost misplacing our focus on it just being on football. The real question to me, I am less concerned at the professional level with, well, what do we do about concussions? Because I think that the answer ultimately is, look, it's an inherent risk in the game. This is what people are signing up to do. It's just a fact. The impacts are gigantic. we've tested every possible advancement in equipment on concussions. We're talking about forces that are so big that even reducing them by 20%, 30% isn't going to have an effect on the overall concussion rate, because these numbers are gigantic. When you hear statistics about, it's like having a hand grenade in your helmet. It's like trying to reduce an explosion in a helmet. It's just that's what the game actually is. Where our focus really needs to be is just on youth sports. I think that what we are not focusing on enough is concussions with kids. It is shocking to me, as we do our research and we have all of our experts, the medical community in treating concussions at the youth level really is lagging behind. I got a call, this is literally just 18 months ago, where my cousin played hockey, he was out on the ice, he blacked out, got hit hard, was just dazed, couldn't think straight, pupils are dilated, can't make a coherent sentence, goes to see a doctor, who supposedly is specializing in concussions, and he said, you know what, you need to take 4 or 5 days off and you'll be fine in a week. That idea of a concussion, of a genuine concussion in somebody who's below the age of even 23, the human brain is not developed until 23. It's shocking to me that even the medical community isn't up to speed on the risk of what is called second impact syndrome. Second impact syndrome is to me, in the coming years, is going to be a very well-known phrase, that because the brain is so vulnerable at an early age, when you receive a concussion, if you get a concussion again, even if it's a tiny impact, it could have severe consequences. It's just like thinking about it like it's an egg. It's like the shell is just barely broken. Then if it just gets touched again, the whole thing could hemorrhage. We did a piece on E60 about a player that you watch the video. The hit seems just completely innocuous. Like it wasn't a big hit at all. It was at the high school level, and the player, now can't talk, is a vegetable for the rest of his life, and everyone's like, how could this happen? The reason why it happened is because he suffered a concussion, a documented concussion. He was told to take a week off, went back out on the field, got a second concussion, and that's now his life. And I think that we, as sports fans, and we in terms of our culture, there's this, you gotta man up, you gotta get back in the game. And when we're talking about concussions, I always like to use the example of, we're not talking about muscling through a sprained ankle, where, you were tough and you gutted it out. I mean, we're talking about a kid's life. And it's a very difficult thing for our society to focus on it and to say, when I played football, I'm 41 years old right now. I played football in high school. I mean, if you sat out because you got your bell rung, you would never play again. I mean, it was the locker room culture is, you got to get back in there. Yeah, your head's ringing. I know exactly what you're talking about. Get back in there. But at the youth level, it's something that's a super serious subject matter that I think we need to address.
I think John makes an excellent point. As a physical therapist, I was very involved in treating youth athletes, and one of the reasons I've taken up the thread of following the concussion epidemic is because I think what happens at the professional level and how they manage the injury has a trickle-down effect, and that's really the important next step. The importance is if youth athletes and the people who coach them and their parents, if they see it's being managed differently at the professional level, they all of a sudden take interest in managing it differently at their level. So I think that's an important piece. We're going to bring up my slides here in a moment, and I'm going to talk a little bit about concussion. I think, do you have the clicker there? It's important to know what a concussion is not. I think people have an image of the concussion being a bruising of the brain, or you take a hit and there's some kind of visual damage that you can see on imaging. And you really have to appreciate that the brain, the analogy I love is like the egg yolk within the shell, and the skull is the shell, and you can still slosh the egg yolk around inside that shell. Well, your brain moves similarly in the skull case. So the damage comes from the shear forces and the vibrations of the brain, either just sliding within the skull or banging up against the side of the skull with an impact. And it's often not visible. So This is a definition of concussion that came out of a consensus conference in Zurich. There's an updated consensus conference statement that is coming out shortly. But a group of medical professionals who got together to talk about concussion in sport, and this definition of a complex pathophysiological process that affects the brain induced by traumatic biomechanics. You saw the DVD of the traumatic biomechanics. Pathophysiological, there's chemical changes that happen in the brain when you suffer a hit. There are electrical changes. Our brain operates on electrical impulses. Those are the things that change, and it affects how we process information. They're not necessarily visible changes on imaging, but they're visible in terms of how we function. It can be caused by a direct blow to the head and neck. Those are the most obvious, but you can also suffer a concussion by taking a blow somewhere else in the body that transmits an impulse force up to the head and is enough to cause damage. Typically, the results are that you will have this episode of neurological impairment, which can be very brief, and they mostly resolve on their own, but not always. The symptoms are more functional than structural, and that's what we were just talking about. In how you process information, how the brain is working, that's where you see the symptoms, not so much a structural change. This is a really important one. It may or may not involve loss of consciousness. You can absolutely have severe consequences from a concussion and never lose consciousness, and that's a really important fact for everyone to know. Grading scales for concussions used to be graded in terms of severity by loss of consciousness as a definition, and the longer you were out, the worse it was. Well, we still don't like people to be unconscious for extended periods of time, but you should not think a concussion is a minor incident if the individual does not lose consciousness. And normally no structural changes on imaging. So why is this so hard for us to manage? Well, I think that's exactly why. It's this invisible injury. It's hard to get your arms around what it is. No two concussions are alike, not only between different people, but within the same individual. You can have a very different experience, one concussion episode to another. And we've found that we still have a lot more to learn. We have more to learn than what we know. So I thought I'd break it down into kind of three key areas. And the first, and perhaps the most important, is recognition. Recognizing when a concussion has happened. In the past, it was completely dependent on the athlete's self-reporting. And tests were as simple as how many fingers am I holding up. And the athlete knew that usually it was 2 or 3, so there was a good chance they could guess it and get it right. Now, we still rely on self-report. Athletes have to be honest, and if they're not, it makes it really difficult on the medical practitioner. But we do have other things. Observing. If you know the athlete, you know when their affect has changed. We have some sideline assessment tools, that scans that they're not perfect, but they are looking at different things, neurological function, balance, etc. And then we have neurocognitive testing. IMPACT is the most familiar to most people. There are several tests that are available. But these are the tests that measure how your brain is processing information, and perhaps are really the key for medical providers to be able to demonstrate to athletes who say, I feel fine, I'm ready to go back, and they can show them, well, you're still showing deficits, and here is where. In the future, sure, we'd like to have technology help us better appreciate when a concussive event is happening, but we're far from perfect in that department. There's the HIT system, which has sensors inside the helmet, which measure G-forces on impact. There's been a lot of study around this. It can transmit that information to a sideline laptop so that the medical personnel has it immediately available. But I think what's important to appreciate is there might be sub-threshold hits. We know that certain G-forces are likely to cause a concussion, but what happens if those forces aren't achieved? You can still have an injury and it may not register. So again, not a perfect system. As far as imaging, there are new methods of imaging the brain that are coming about. DTI, or diffuser tension imaging, it looks at water flow in the axons of the brain and can give us some information about where the damage is occurring. I think this is really exciting because to me it's one of the best visuals in terms of lost axon function. And at UCLA, they're looking at biomarkers to detect tau proteins. You may have heard of tau in the news. That's the protein that's associated with CTE. We've heard so much about this. The problem so far has been you can only diagnose CTE post-mortem. This is only a pilot study, but they looked at 5 living retired NFL players and found that this radioactive marker would attach itself to tau proteins, and they could identify them in these individuals who are still alive. So again, some promising research there. This is just a picture of the DTI where you can see on the bottom, you're looking at the left and the right side of the brain. They should mirror one another. And the top, where you have the deficit and the water flow has changed through the axons in the brain, the fiber tracts, you're actually seeing an absence of that part of the brain showing up. So this is very exciting work being done out of University of Pittsburgh. As far as treatment, again, we don't have the answers now, but we know that they used to just tell people, although based on what John said, it's not so much used to. You know, go sit in a room, be quiet, draw the shades, don't do anything. Well, as somebody who has done rehab for a living, it's hard to imagine that we rehabilitate everything else. Why would we not do the same thing with the brain? Why would we just tell people to go and leave it alone? And I think it's just because we haven't understood how to do that. Now we do know rest is appropriate. We have found that there are some medical interventions. The folks at Pittsburgh are doing some interesting thing with medical combinations in certain cases where it's appropriate. There are some rehab strategies to target the balance and the vestibular system that are being investigated, and we know that it's important to return someone to activity slowly. Not just athletic activity, but in the case of youth athletes, school activity. Your brain does work when you're at school, theoretically. Your brain works when you're texting. I don't know, but that's what theoretically it does. So all these things, all the stimuli, that puts stress on the brain, so we have to modulate that when somebody's recovering. And as far as the future, who knows? We have so much to learn about treatment. And then prevention. Can we really prevent concussions? I don't think we can prevent them entirely. In the past, there was no attempt to, we didn't even acknowledge they existed, so we really didn't work on preventing them. Now, our best measure in tackling this is education, teaching kids proper techniques, as well as coaches. We see legislation of greater penalties in the professional sports leagues, and hopefully in youth and in youth sports as well. Technology, we'd like to see technology help us in preventing concussions. I see a lot of money going into helmet technology, but remember that egg, shell, and yolk analogy. The helmet is still outside the skull. So the helmets are doing a good job of protecting against skull fractures, but they're really not protecting against the concussion that's happening inside the skull. I'm just going to race through these quickly. We've seen some league changes. The NFL, perhaps the most visible in terms of making rule changes. Return to play guidelines have been modified. We've seen they're going sideline tools becoming more uniform across the league. They're going to an iPad version of this sideline tool this year. The eye in the sky, having another set of eyes in the booth to monitor what's happening on the field. An independent neurologist, again, this is a point of contention among some of the medical staffs, mostly because we still understand that knowing the affect, knowing a player does a lot when you're trying to determine if they're off. So we don't know how much the independent person is going to help. If you look at the other leagues, Major League Baseball went to the 7-day DL in 2011. They added a special grouping for those who had suffered a concussion. The NBA has made a uniform policy related to baseline testing and return to play. And you may have, if you followed the sports news, there were some outspoken comments against the concussion policy and how foolish it was. Sometimes we have to protect athletes and coaches from the concepts they bring from the past in terms of managing concussion. In NASCAR, with the very high-profile case of Dale Earnhardt Jr. last year, now considering this baseline neurocognitive testing to be implemented potentially by next year. So the sports leagues are making some changes, and again, I feel that's important because of the message it sends down to the youth athletes, which really is the key for me. We know that concussions exist in all sports. As John mentioned, we have to look at everything. Concussions can happen anywhere. And in a study in the Journal of Athletic Training in 2007, per exposure, meaning practice or game, girls soccer rated second in terms of number of concussions to boys football. We see that there are different modes of sustaining a concussion. Football, it's contact with another person. Baseball, it's contact with equipment. We have to change how youth sports handle concussions, and these are some of the entities that have been working on that. Unfortunately, at the high school level, they cannot mandate from a national oversight body how they're handled in high school. So we rely a lot on state laws, and the LISTET law was the law passed in Washington State as a result of a second impact syndrome that really changed allowing kids to go back into sport after suffering a concussion. And now I believe it's 40 states have similar legislation after Washington just brought it on a few years ago. So there's quite a ways to go. That was like a very cursory overview of concussion, but to me, that, like John said, this is really one of the biggest topics in terms of what we're seeing in sports. So we wanted to share some of that with you. I'm going to circle back with the panel for a moment because just coming off that concussion topic, Stan, we see all this with protective headgear in football we've talked about. Baseball was talking about protective headgear and looking at some things. They decided not to go with it. I think after Brandon McCarthy, you may remember last year, took a pitch to the head, ended up needing skull surgery. They were looking at protective headgear for pitchers. Can you talk a little bit about where baseball is on that and what they're doing to protect against concussions?
Well, I think it first started with the coaches. If you recall, several years ago, a minor league coach got hit by a bat, ended up dying. He actually didn't get hit in the head, but he got hit by a bat and died.
Again, the slide about equipment.
And so then they mandated that all the coaches at the major league level and minor league level wore helmets when they were on the field, first and third base coaches. They used regular helmets similar to what catchers use, which is interesting only in the sense that those are at NOCSA levels. NOCSA is a good housekeeping seal of approval for helmets, but those are only tested at 60 miles per hour. So if they meet those standards at 60 miles per hour based on an SI score. Now, because of the McCarthy situation, they're thinking about trying to protect the pitchers from getting hit from line drives. They have an unbelievable, John probably knows the time of seconds that a line drive comes back. And they're looking at putting some type of liner in the helmet, in the hat, and not having the pitcher wear a helmet, which they think would interfere with the game. And they've come up with several close. They're just not close enough. They're Kevlar padding with different layers. I've seen them, and I've put them on, and they're still not quite comfortable enough. But I think by next year they'll probably have those. I think pitchers, in years past, and this kind of goes to your point about concussions and maybe the trickle-down feeling is that I would say 5 years ago there was no way that a pitcher would even consider wearing headgear when he pitched. Mm-hmm. And the pitchers I've talked to said they would try it. And that is a huge shift in what's going on. The other thing on the impact test, if anybody has an opportunity to take an impact test, your local high school has one or something, take one. As you take the test, you can feel different parts of your brain functioning. I know that sounds weird, but in the different questions and how they do it, you can actually, it tests different parts of your brain. And I would encourage you to take that test. It takes about 20 minutes or so, and you can get the idea of how your brain works. And in regards to treatment on second impacts, I think you make a great point. I was involved in the Mike Matheny situation where on a foul tip, he took a second hit, ended his career. He actually, when you looked at his history, took multiple hits, had multiple non-diagnosed concussions. That is a real important point. And the idea of treatment, as Stefania was talking about, the first part is rest, but it's not a muscle and it's not a tendon, it's not an ankle, it's your brain. So if you sit at home and rest watching TV, you're not resting your brain. It is literally pull the drapes in a dark room with no stimulation. Everything you do is using your brain. So if you broke your arm, you wouldn't be moving your arm all around. And that's a hard thing for people to understand.
The other, I don't know, John, if you've seen this in some of the sports science things, but looking at what happens with collisions at the plate. The other area of interest to me is behind the plate are not only catchers, but there are umpires. And there's, just in talking with some umpires, I've found that some have, in the minor leagues, have not been able to even progress up to the major leagues. They had to basically retire early because of repetitive concussions from taking foul tips to the umpire's mask?
We've looked at every possible kind of collision in sports, and we compare collisions at home plate to returning a kickoff in the NFL, to smashing in the wall in NASCAR. I mean, what's interesting about baseball, and I think the comebacker is a great example of, standing out on the field, pitcher throws a ball, if it releases his hand, say at 90 miles an hour, it can come back to him at 120 plus miles an hour, but he's now standing, 10 feet closer than when he actually released the ball. You've got about 0.3 seconds to react. The human brain takes 0.1 seconds to even register light in the brain. It takes 0.15 seconds to fire a signal and tell your body to move, so it leaves you about 5/100ths of a second to do something. Can't move your hand fast enough. Like when you start doing the math on it, it's frightening of like, oh my God, I can't believe the impact that's out there. But it's like that in what I like to point to is we have, the data and the stats on everything, on like, oh my God, I can't believe that is out there. What are we gonna do about it? The reason why I'm so obsessed with at sort of the youth level is I like to analogize it to amateur boxing. We make amateur boxers wear headgear. You wear headgear in the Olympics, you're protecting yourself, but once you reach up at the professional level, you take the headgear off and you're assuming a risk because you're getting paid lots of money to do it. I feel like the focus on everything in the prevention and rehab really needs to be very focused on the youth level because there's a certain amount of risk that you're taking at the professional level that I think that's inherent to the game.
I want to come back to Dr. Vehling's work a little bit. This is in the area of, it's biologic therapy, right? You're using your body's own healing response. You're helping facilitate that. Can you explain, you said this is different from stem cell therapy, from PRP. Can you explain how what your process is different from those therapies?
Yeah, the difference, I don't know if it should take. The difference is based on part of the biology of the protein solutions. So when you compare the PRP, which is thrombocyte concentrate, platelet-rich plasma, the anti-inflammatory effect of the serum we use is 140 times stronger. When you look to stem cells, that's an interesting issue. We personally have some good hints that actually it's not the stem cell that would work, but what the stem cell produce. And in a way, in the serum we use, there are also components that are actually produced by the stem cells. Just briefly, just from a clinical standpoint, with the autologous condition serum in the Regenokine system, we have randomized double-blinded studies. And there's also biological concept behind, but you don't know exactly always what is going on because it's a complex system. And coming to the concussion story, I think there's a very interesting parallel to the injury of all the other areas. So it was very interesting to listen to you. I think there is a principal reaction from the body to trauma, and it always induces inflammation. And I think one approach could be in concussions also to think about the effect of inflammation, because the trauma itself is, the biology of the trauma is the same in the joint or muscle or brain, but the clinical features are obviously much more severe. But when you look into the biology of the brain, of the cells, the mesenchymal cells, I think there's something very similar going on, and as in all the tissues.
And what sort of success rate are you seeing with the procedures that you're using?
We know from the clinical studies and also from the documentation of cases that in average from 100 people, 75 would profit from it. Significantly, clinically significant, but it also means that around 25% or 20% do not profit. So
when you talk about profit, how you gauge your success, I mean, in sports medicine, the success is returning to their previous level of performance, not just, feeling better. So when you say 75 or 80%, what do you mean by that?
Yeah,
success rate?
in this context, there are very well approved scores. There's a VOMEC score or the Oswestry score. So it means that there is at least a 50% decrease in the VOMEC score when you talk about knee, but in delay of surgery, for instance, in shoulder issues or in knee things, you can talk between 2 to 4 years. And in return to the sports, in the responders, it's very hard to do a very good study because sports people, double-blinded studies, nobody does a double-blinded study in sport. So that's a problem also in muscle regeneration. I think it's a big problem with concussion studies too, because high-profile sports people do not agree, but clinically from the experience, when the patients have a knee injury, they actually would start after the treatment, they go into the training just during the treatment already, depending on the injury, and you have a shorter rehab compared to the operation. But I don't want to say operation is bad or this is good. Everything has the right indication. That's the art.
That's right, because everyone's unique and brings their own unique health history to it. That's the problem. I think we try and see these, and I see it a lot in terms of reporting on injuries. They're like a blanket. Everybody says, oh, well, if they've done this, they should all be back. Not everyone is Adrian Peterson, everybody. So not everybody after an ACL, MCL surgery is going to come back at that level in that time frame. So I think it's important to recognize that in medicine, you're always trying to balance how you provide a treatment that's effective for multiple people when everybody brings their own unique history and body type, and et cetera.
Yeah, that said, my GM doesn't care if it feels better. He needs to get out back on the field and perform, not just get back on the field either. So at the professional level, it's a totally different thing in regards to that. And I think you make a good point. Everyone's unique. Not all Tommy John surgeries come back at 100% and perform at they previously did or better. They don't do that. There's a certain probability that they won't. It's small, but it's there. And
but perhaps one last comment to that interesting thing. I think the gene testing will give the answer. When you look into the knee injuries, we now pretty well understand what patients react well to surgery and which will react better to non-operative treatments. So I think there's a big shift of paradigm.
Is that going to be
we
the
got a very good
future,
understanding
that we're going to have a genetic testing component to our treatments?
Yeah, I think that's the future, and we are really at the edge with our system. We found the genes to distinguish what treatment modality has a higher impact, because the studies actually don't reflect the player situation. Every case is different. And although you do a randomized study, it's only an average, but for the single case, it's 100%. Right. So that's a big thing.
I think Mark Cuban in his opening remarks talked about genotyping and use of anti-inflammatories, which I found interesting. I think that probably is, when we talk about PRP that gets a lot of press and whether it's successful or not in stem cells, I think genotyping is definitely in DNA testing is going to be the next level in what we do with that.
We have some questions from the audience that have come in through Twitter, so I'm going to put these out to the group. I love the honesty in this one. How can you effectively counter the man-up attitude in sports?
Get more women involved. They changed soccer.
See, I love that question. I love it.
I thought you might.
And here's I think what illustrates the dilemma. So let's think of this dilemma. Take the UFC, for example. The UFC, if you get a concussion at the UFC, if you get knocked out at the UFC, you are not allowed to do anything for 90 days, 3 months. Imagine if that standard was applied to every sport. You get a concussion at the high school level, you get a concussion game 1, you're never playing football. And you're saying, so what's the correct standard? Is it take a week off, take a month off, take 90 days off? Like, where is it? And there's no sport that's more man up than the UFC. Yeah. And so you have this dilemma of what is the standard, what is the injury, it so depends on what it actually is. I don't know.
Exactly.
It's
Well, it's going to get worse too. It probably already has got worse in the NFL, but the players know that the tests are coming when they get hit.
Yeah.
They know what to say, and they really work hard. This is why it has to be objective. In baseball, it's really tough because the typical concussions we have are probably subclinical concussion with foul tips to catchers or collision at the plate. Well, in football or in hockey, you take those players out, you evaluate them, and then they can go back in if they're okay, and not in baseball. So if you're a catcher, then this is where the real life gets involved, and we talk about manning up, but also pressure to keep players on the field, and where we might skirt the boundaries of medical knowledge is that if I take a catcher out from a foul tip, because I'm not sure if he has a concussion in the second inning, that's not good. We have one more catcher. You know what happens when you lose two catchers? The outfielder is catching. And the reason we use an outfielder is because he can run really fast back to the backstop to get the ball, because that's what happens. So there's a huge amount of pressure. When I run on the field with a catcher in the second inning on a foul tip, and remember, I live Mike Matheny, so I think about this all the time. And you think, I really should take him out. And I'm thinking, oh God. And the manager's standing next to you saying, he's okay, isn't he? He's okay. And of course the player's saying, I get these are fine. And when Mike Matheny, which was unbelievably interesting, is eventually we finally got him to say, well, he says, when I get hit in the mask, he was talking to another catcher, he said, when I get hit in the mask, I black out for a second, like everybody does. And the other catcher said, what? I don't black out. He was blacking out on every foul tip. He also said, for the next 3 at-bats, he couldn't see the ball. And that was like through 3 years of his career.
I think like the whole man-up idea, and think of the iconic images we have of Willis Reed, right? Or Emmitt Smith playing with a separated shoulder, or whatever. You have like these ideas. You then take to RG3. Everybody was outraged that RG3 kept playing, but Jay Cutler the year before, everyone's
Perfect
like,
example.
what a wuss. That guy had to get back in the game. What was RG3 doing on the field?
I think to take the RG3 a step further, everybody was outraged that his knee seemed to be a problem, and he still played more so than when he had a concussion.
Right.
And
You're 100% right.
That was disturbing to those of us in medicine, that everybody cared. What, his knee? That could threaten him for next year. I'm like, oh, not the brain.
He had a concussion. I know. It's like what do we do about man up? It's like the arguments where everybody speaks out of 10 sides of their mouth.
I just want to get one more question in quickly, and it's for Dr. Veiling, and I think it's interesting because I think there's a perception about performance enhancement that goes with a lot of these novel treatments. And someone asked, can ACS be used not just for injured athletes, but for healthy athletes to increase performance?
No, absolutely not.
We need your mic.
We treat patients, and when I discussed the whole matter, we only started to treat high-profile sports people when we had the clearance from the World Agency Against Doping. So that was, with these kind of people, you can't mess around in that aspect. And the reason why the WADA, that's the World Agency Against Doping, cleared it, that because it's a local therapy, you're allowed to inject it in certain amounts, and in this amounts you inject it, it has no enhancing effect at all. Like PRP is clear too, so that's important. You never endanger the sports people, and you only do it with a medical indication, and it's clearly not a performance enhancing effect.
Well, I want to thank everybody for coming. I want to thank the panelists, John Brinkus, Dr. Peter Veiling, Stan Conti. Thank you so much, and thank you to the group for inviting us.